hopefully accelerate very quickly in the early part of the hour. But without further ado, we might as well kick off. Kia ora to everybody who's joined us today. Thank you for joining us. Really appreciate that you guys are taking the time out of your busy days to come and see what Shirley is all about. For those of you who don't know me, I am Alex Koppel-Chantraine. I am Medtech's Integrations Program Manager, and today we have with us Jason Gleason from Shirley, which integrates with Medtech via our interoperability platform, Alex. So I'm sure there will be many of you who have questions possibly already and some coming up throughout the webinar. So as these pop up, please feel free to pop those into the Q&A box down the bottom of your screen. And Jason will aim to get through as many of those as possible before the end of the webinar. In the event your question is not answered in the webinar, we will ensure we get all of those contact and question details sent through to the Shirley team after the webinar, and we'll make sure that those get followed up. So for any who have colleagues and associates also who may have been unable to attend for any reason whatsoever, couldn't fit it into their schedule, we are recording this session, so we will be, of course, happy to pass that along to anybody who's interested or who wants to pass it on to any associates or interested parties. Without further ado, I will pass over to who we're actually here to hear from. So take it away, Jason.
Great. Thanks, Alex. Hey, kia ora. It's nice to meet you all. I'm going to run through a short presentation, I guess, explaining what Shirley does and how it works and a bit of our goals and story behind this, and then actually a demo of how it operates from the requester's perspective. There is another part of this which it does have an interaction with the PMS, with Medtech, but I don't have access to that. So I can just, you'll see some screenshots and everything of it. But my goal from this, at least, is to explain, a bit more around why we built this, what our purposes for it are, our goals, and really, I'd love to, here again, answer any questions that you may have around this as well. So I'm going to drive Zoom badly, just as a warning, and. See if I can get desktop. And unfortunately, Alex, you weren't, your gremlins are back. I have to restart Zoom to share my desktop. So really sorry about this. I'll be back in 2 seconds, everyone. Sorry about that.
I'll give some context to that. Zoom updates appear to have gone through today. So hopefully those aren't going to cause too many issues. But we should have Jason back with us shortly. That's good, though, because it actually gives, we have a few more people jumping in at this stage. So we'll give it a few minutes for Jason to get everything together, and we'll see where we go. And some of you may have already joined with questions already in mind. If you've read anything about Shirley and you have some questions, please, of course, feel free to pop those directly into the Q&A box down the very bottom of the screen. If you've got some floating around, if you don't, then that's great. But and of course, if you have any pop up during the webinar, please don't hesitate to put those into the Q&A box down the bottom.
Great. Sorry about that. It was the classic needing to change my system settings. So great. So got that little hurdle out of the way. I can jump into this. All right. So the idea behind Shirley is we really want to optimize access to health records, and we're really trying to meet two requirements at the same time. So this came from, the whole idea of this actually came from, ironically enough, a visit to my GP, and he was muttering under his breath as he was typing in some notes into the PMS, something about how he didn't go to medical school to spend all of his time filling out paperwork, which I'm sure is a similar element to many of you on this call. And so in part of the conversation I had with him, I was like, well, how much time is this? And, from his own experience, it was sort of 4 hours a week, fielding requests for health records from, some of this is for referrals, but also it's from external third parties or patients that need their health information for some purpose. And so we did a little bit of research, and we came across the Royal College of GPs research around this, and found that this kind of admin overhead is out of clinic time. It's a massive drain on your enthusiasm and mental health and desire to work in the space. And being a data exchange company, we're like, well, this is something I think we could try and solve. So the idea behind Surely is that we want to strike the balance between speed and privacy. So we don't want to simply take a process that was based on phone calls and emails and then just make it just as annoying, like in your PMS. We want to build this in a way where it's, we're not pinging you for requests or for information all the time, and we're not distracting you or taking you away from something. But at the same time, we're also not just spraying information everywhere. So the idea around this is that we took from a design perspective is that GPs are only required when needed, and can monitor all of the requests. So every time that Shirley is interacting with your PMS, you'll know it. We'll send you a note inside of your inbox saying, this person or this health care organization or someone has requested access to this patient, to this patient's records, and you'll then be able to interact with that as needed. So in some cases, it's just a notification because it's a telehealth provider, and you can just go, cool, that's fine, I'm okay with this. Or if you're not okay with it, you can also interact with us through that to let us know that you wouldn't like that information not to be shared or something along those lines. At the other end of the spectrum, there are government agencies that request a lot of information that we feel that GPs should be more on top of. So in that case, when it's a third party outside the health sector that may not be acting on behalf of the patient, we will then change the engagement model and say, actually, you need to review this report, and you can redact what you don't feel it should go through, what you have more control around consent and control. And the other side of this too is that patients receive the right sized health records. One of the things that we're also trying to deal with is this imbalance between request and response. So what we see a lot of times, and this is certainly in the case of agencies and private enterprises, is they really only need to know about a few things about an individual. Maybe they need to verify disability status, or if it's someone applying for insurance, they need to know about a couple of conditions. And it's just all too often they end up receiving the entire health record. And so we're doing a lot of work behind the scenes to go, actually, let's shave out everything does not specifically apply to those requests, and using some pretty clever technology to do that, so that only what's being asked for is sent through. The privacy is not, the patient's not exposed to any greater privacy scope than what they are entitled to. So the challenges in here, again, I feel like I am probably preaching to the choir a bit, but it's high administrative overheads. It's inbox management, patient administration. I think the GCP or Royal College of GPs survey found that this was a contributor to burnout 96% of the time. It's also the time spent responding to requests. So unfortunately, because you're holding that information and you know kind of what's in there, that load is simply passed on to GPs. It's not being shouldered by the person making the request to actually fine tune things a bit more or do anything smarter. It's just sort of like, here we go, we need all this information, can you please give it to us? Thanks. The other thing that we found as well is that tech needs to take a back seat. And this is one of my personal bugbears coming from the technology sector is, I've always been very frustrated in the space, and that tech just seemed to make things more complicated. It's sort of like I would go to conferences and they'd say like, here's this complex business process. We'll just install this software and it will make it all go away. I'm like, well, no, that's more tech, that's more business process. We actually need to operate in a way where everyone is able to do their own jobs, do what they need to do, and the technology is just kind of seamlessly, quietly behind the scenes working and facilitating that. And finally, the part of it too is a big part too is the coordination with external parties. I mean, it's I feel that it's, and we found in our research, that it's very easy for agencies to just pick up the phone call and make requests, and these sort of third-party organizations to make these requests on GPs without really coordinating them any better or realizing, the amount of impact that they're actually having on providing primary care. So I am, just as a confession, I love puns, so that's why we named it Shirley, because Shirley the much better way. But AMIA is a better approach to sharing health records. So one thing we want to do is accelerate the consent process. So in this case, what we have is we're doing a lot of work before anyone can even make a request to verify who they are. We're verifying their clinic. We're putting a lot of load onto them to document why this request is being made in the first place. And a lot of this is so that we know that when that request goes to you, all of those checks and balances are already kind of in place. The second part of this too is that it's patient controlled. So the idea here is that the patient is ultimately, again, if it's a third party, so if it's the patient requesting their health records for someone for some other purpose, like licensing or insurance or whatever they have, that patient ultimately controls sending it on. They're not left out of the loop at all. Again, unless it's that third option. We're working on the ability of handling specific conditions only. So coming up fairly soon, what the request will be is the person making the request will need to actually search through and select SNOMED conditions that they are interested, that they need information on. When we pull the report through, we're going to strip out everything that doesn't match those conditions and just pass that through. So it kind of gets back to that whole small request, small response, not small request, everything. And finally, and the other thing too is the idea around GP consent revocation. You can refuse any request that comes through. We won't pull anything without your ability to step in and go, no, that shouldn't go out for that purpose. And then from a technology perspective, because runs on technology, we integrate completely behind the scenes. So if you're using Alex, you will be here. If you're using Alex and your PMS, you don't need to do anything on your side. We're talking to the PMS behind the scenes and working with it in that way. We verify everyone that does make a request. So we actually, in order for someone to log into Surely to make a request, they have to log into their own corporate system first. And then that corporate system tells us that they're okay. So it can't be drjason@gmail.com. That wants to come in and start pulling reports. We have to actually authenticate with their employer that they actually work there and they are who they are. The security part is quite interesting. As a company, this product is built on the 8Wire data sharing platform. This is a technology company that I founded in 2013, and we are classified for handling restricted classified data. So we handle the most sensitive information in the country that you can have on the internet. I think if anyone wants to send anything any higher than that, it's not online. It's kind of, you're locked away in a room with a USB key. And we also have a SOC 2 certification, which is an international standard for data security and data auditing. So we take security very seriously, and we also take privacy very seriously. So we have a privacy impact assessment that we've done for this, and we've been working very closely with our consultants in that space to make sure that this meets privacy needs and improves them. We want this to improve privacy if possible. So the way it looks like for practices is, as a GP, you can, all you need to do is review a request detail. So you'll get a message in your inbox which says either a clinic or a healthcare provider has requested patient records for one of your patients, or a patient has requested them. You can review those details. You'll be able to see what's being sent. And so if you're not 100% happy with that, then we won't send it. You can request revoke access. You can say, no, they shouldn't have that. And in which case, what we'll probably do is just facilitate a conversation. We'll say, okay, well, this is the person, this is the organization requesting it. You guys need to have a chat. Or at the same time, you can improve access. What we do is we verify the permissions, we validate the patient details in the clinics. We also, again, verify all the consent. So before anyone can make a request from us, they have to have proven to us that they are asking us for a real reason. So I'll show you the portal, how it looks, but behind the scenes, there's actually a lot of integration within their own clinical systems or their own sort of customer case management systems. We also handle like the communication between GPs and patients and these external parties. So again, if there's a problem, we'll bring everyone together to have a conversation, and figure out what's going on. And finally, we retrieve the health records from the PMS, and then we transfer them through and then delete them. So the key thing here is that there's no storage any longer than absolutely necessary, which is about 3 days. We give a process 3 days to run, assuming that someone, accounting for someone putting a request to you on a Friday and they're not going to look at it until Monday, kind of thing. But across the board, as soon as the process is completed, it's all deleted, and you'll see that in here. So 3 levels of engagement that we have. So one is if the request is coming from some sort of certified healthcare provider. So for example, we're doing quite a bit of work with telehealth and aged care providers because they are responsible for providing care. They have a relationship with the patient, but they're not in the primary space where they have direct access to their notes or to their information in the PMS. So if it's a certified healthcare provider, they make the request. Again, you will see it come through on your PMS saying, this is this clinic so and so. Let's say it's a third age health provider for Ryman Healthcare. I have requested access to this clinic or to this patient. If you have a problem, contact us. And then behind the scenes, we'll move that across. If the patient is approved the request, so this is the next stage, which is really when you're starting to kind of come out of the healthcare sector a bit. So someone on behalf of the patient has made that request. So it could be, the example we use here is someone applying for a license that has a health requirement. We will, same thing, we'll notify you what's going on. We will notify your patient, in this case, has requested some information, has requested health records. But that won't be released until the patient goes into their email and actually releases them. So if you're okay with it and they're okay with it, the record goes through. If either side is not, then it stops and it won't pass through. And finally, the third one is if it's a request on behalf of a patient. And this is a fairly niche approach, but this would be when, for example, if it's from, like, say, New Zealand Police is carrying on an investigation and they're gathering evidence and they need some health records for that, then the request would be initiated by the police in this case, and we would send it straight to you. And then you would then have the ability to see the request, the record response of what it is, and then as the GPs, you could then allow it to proceed or not. And then again, there's no other interference or no one else can kind of come in and override it. It's completely up to you. So here's a quick example of how it would look and operate. So we have Johnson, who is a Civil Aviation Administration, I think they're called, examiner, requesting special conditions regarding an applicant's eye surgery for a medical certification. So you just need some more information to kind of know to make a decision. So Johnson, who has a login to Shirley, would select the specific health conditions that he's looking for. So he would, again, look up a SNOMED classification to see what he is, and submit the request to us. We would then, first thing we do is we would notify you as the practice or as the GP and say, Matt, your patient, has had a request for their details. This is the payload of information we're actually going to send to them. So this is the actual report detailing, again, his eye, anything around his eye surgery and treatment and recovery. And at the same time, we're also notifying Matt that his report has been requested and it's up to him to release it. And again, if I think we have it on the next page here. Yep. So if the GP is okay, and basically by being okay means you don't do anything, you don't have to actually interact with it. You can just kind of assess it and kind of go, okay, cool, that's fine. Again, we don't want you having to interact with this too much unless you feel like you really need to. We will then allow the patient, Matt, to push a button, and then that releases the report onto the CAA. And the report looks like this. Very, very basic. Honestly, it's not that exciting, I don't think. But what we're pulling out is, personal details, contact info, conditions, medications, allergies, immunizations, screenings, lab results, and notes. And I'll get to the notes towards the end because we have a few questions around that because we haven't implemented notes yet. So I would really love to get some feedback and thoughts from you all on this. But what we'd have as well would be, again, the data processing machine, because it's specific conditions, would only reply with, say, screenings and results and notes that dealt with his eye surgery. So here's where we're at today. So we launched in April on Alex. And so we're working at the moment with Medtech Evo practices, and we'll be launching on 32 fairly soon. We're just putting the final steps in that because they're both very similar, so we're able to do that. After this, we're in the process of building the indice integration. So it's planned for late June, and then my practice in July. So our goal is to have and then there's IntraHealth as well later this year. So our goal is to have every practice in the country to have this ability, again, to work with them for reducing these kinds of admin overheads. So now the fun/scary part is I'm going to do a demo. So I've logged in to my to Shirley here. And so the requester, and I'm going to actually pull my own health report in this case. So the requester in this case has the ability to look up by either their NHI number, so NHI, email, and clinic, and the email, by the way, this is the email that we use to contact them for them to release it, or their personal information. So they can also do a search by first name, last name, email, the email that the clinic has, their phone number, and their date of birth in their clinic. Cool. So, and I believe I've done this enough times. I think I've memorized my NHI number. Let's really quick and check it. RQ894. Yep. And my email, and then my clinic, the City Medical here in Wellington. And then I review the request. So, yep, that's the correct NHI. That's my email address. That is the medical center in my spent. And it's now being processed. So over here, you can see it has a pending status. If I refresh this in a few seconds, it'll say awaiting consent. So what's happened now is there's, and unfortunately I can't show you on the PMS slide, but there's a message inside the, there will be, we're going live today with the GP comms into the PMSs, but there will be a message inside of the PMS for the GP to assess. And at the same time, there's an email in my inbox. So I'm going to go find, here we go. Health records ready for sharing. So here's the email. Hello, Jason James, your consent is required, review and consent. So I open this. And again, there's more information. So I can, review this. If this makes sense to me, or if I'm like, well, I've never heard of this, I can decline it. And any declines, we would basically reach out and go, hey, were you expecting that? If this is an issue or something, and we know someone's requesting reports they shouldn't be, then we'll go after them. But yeah, the key thing is that do that, I approve it, and well done. So I go back into here. So the awaiting consent one. So that's all consented. And now I can access the report. And so what's going to happen then is it's going to be spooling up this information and then downloading onto here, and then and then I can then kind of carry on. So that is again, from the standpoint of how this works. Again, it's a very simple thing. You wouldn't believe it took us this long to build. But the few things that we do have, I'm trying to think if I just check my a few things that we do have that we are going to be rolling out fairly soon is, again, specific conditions. So this will change to where we'll have a lookup into SNOMED CT, and then someone you could, the request would actually be for conditions. And then that report, we would actually use a machine learning algorithm to match up those conditions with anything in the report that matches them as well. So basically the entire report was going to be categorized, every line of text we categorized with whichever SNOMED condition it applies to, and then we just match up the codes and then bring through the ones that apply. And that's really where we want to get to. And my last question, because this is probably the first and main chance I'm ever going to have to get in front of a whole group of GPs, is I'd love to, if you have the time and if you could put something into the chat, I would love to hear any of your answers to these questions. Like, who do you commonly receive requests from? We've done some research, and we know who some of the organizations are that do a lot of make up the bulk of them. But it'd be great to find out whomever else you'll be getting kind of these sort of requests for health records from, and we can talk to them. And again, our ultimate goal is that the phone stops ringing and the emails stop kind of coming in, and you're able to just sort of work with what you have. The second thing is really, and we're being very careful around clinical notes. So there's a lot of room that we can do around, a lot of work that we can do, I think, around getting GPs comfortable with this. I think in the past, and the way this has been done is because of the privacy and the sensitivity of the notes, it just defaulted to like, okay, well, we'll just let someone do something by hand. And again, we're back into the bad old days of spending hours, 15 minutes, 20 minutes, 45 minutes, or whatever, going through a patient's notes. So I guess the question here is like, what would make you comfortable with sharing them? Is it something where, we would highlight with you these specific ones that are being shared? Is it, additional rights of relocation, or anything that would help in that space would be really appreciated. And the third one really is, this doesn't just need to be data from PMSs. It's also kind of going into them. So a third question is, who do you need health records from that we could add to this? Because, again, if it's a way that, we could have something running inside of Medtech where, you can just say, I need these records for this patient from radiology or from physiotherapy or from someone else, and we have them on that network and we can kind of bring them in. That's certainly something we'd like to do as well. But yeah, so that's good. I was hoping to get half an hour talking and then half an hour of questions. So I feel like I'm right on time. And that's a picture of me years ago when I was much happier and healthier. Are there any questions or anything anyone has?
It looks like we've got a few questions in the Q&A box. If you see that down on the bottom, Jason, if you click on the Q&A down once you're not sharing.
Got it. I'm sharing.
Yeah.
Cool.
Do you see a Q&A box down the bottom with a little red number? Yeah, perfect.
Sure. Yep,
we've got a few.
Cool. So the first question is from Gina Walker saying, can you please cover how requests are received with clear indications the patient has consented to information being shared? The portal that you saw here is really a demonstration of how this works. In reality, it's going to be something much more bland and nowhere near as nice. So for example, within most of the organizations we're talking from, they're making the request from some computer system application they're using. It could be a care management system. It could be, an aged care. It could be something like vCare or eCase, where they're, walking around the homes, using a tablet or a phone for entering information. And so we actually would plug into that. And so part of any organization that we bring on as a requester, we go through this pretty long process of kind of nailing down how consent is granted. So we're doing things like we're going through their paperwork, and we're like, okay, so I want to see the form that when someone signs up, which says, I consent to you accessing my health records. Or we need to see something inside that system which says, you can only trigger this when these criteria have been met. so it's a way sort of kind of programmatically trying to control that, so that yeah, it's not it wouldn't be yeah I would be, to be honest, I'd be very surprised if anyone just starts hammering in NHI numbers into this portal. I think it's a demonstration purpose of how it kind of works and operates, but in an enterprise sort of space, it will be, they'd be in their own management systems or their own clinical systems, and we would be checking that before that happens. So next question from Anonymous. Jason, does that mean that the requester will have access to a list of patients' classifications without any consent being given in order to pick the relevant ones, or is it a generic list of codes that's provided? It's a generic list, so we don't feed them anything to say like, "Are you interested in one of these?" Or it looks like you're looking at it this way. They have to know those conditions first to make the request. So we won't prompt them or give them any hints or anything. It's sort of and an example, going back to the CAA example, it's like these conditions have already been raised through some external engagement with that patient. So when that request is being made, they already kind of know that, okay, well, we need to know more about, again, their ophthalmological surgery and their recovery from it. So I'm going to search those and look up those those conditions and request them specifically. So yeah, so they have to before they ever come to us. Ask again, is there a cost to practices for implementing the solution? Or will it be included in our Medtech evolution licensing cost? This is the best answer possible. It is free. So there will be no cost to you for using this. And the implementation is done behind the scenes through working with Medtech around the Alex integration platform. So yeah, there won't be a cost, and there never will be. And I'm the person in charge, so I get to make that decision. And on the other side as well, I think it is important to us that there are benefits here. So our focus is on improving these sorts of outcomes and benefits for each of you. Does Shirley know where the patient is currently registered? We don't at the moment. We are trying to get some traction with Te Whatu Ora to get access to the National Enrollment Service, and being able to use that to look up where the patient is enrolled or where they're registered. But at the moment, yeah, we have to find out the clinic from them. But in the future, our intention is to, if we can access the NES, we can then, with our NHI number, we can find which clinic they're in. And we already have access to the NHI API, so we may actually be able to kind of wind back a bit on that NHI response, because maybe you do have a case where someone, like as you saw with me, trying to remember my NHI, and I certainly did not know it before this, before doing all these demos. Being able to simply, a customer can authenticate their identity through, proof of address, name, first name, surname, gender, and date of birth, I think is all that's needed, and then we can then use that to find the NHI. Cool. Thanks, So yeah, I think she's answering my question. Who makes the request? So it's ACC, police, SureMed, ConnectNet, and other insurance companies, and other GPs, and the patients themselves. So yeah, so that's good. I guess I've talked about this a bit before on the work we do in the government space, but we've actually 8Wire, which is the company that has built and runs this. We have been working with ACC and police and corrections and other agencies for going on 7 years now. So part of this is then also trying to talk to them and go like, hey, look, let's stop hassling GPs. We'll build the new systems and then we'll do some verification so this can work in that way. Will surely replace GP to GP. It's a tough one. I feel like we're a bit that we've had a lot of internal questions around, and a lot of internal discussion around if we would look at a replacement for GP to GP. And we've had some conversations with, I think it's in the doctor. I think that is, or someone, or maybe it is Royal College of GPs that's setting up a working group for its eventual replacement. So yeah, it's something we've kind of talked about, but we haven't invested any time more than just going, that could work. So that's yeah, as far as we've kind of gone with that one. But yeah, I would think, but certainly, I mean, the purpose and the idea behind what we do is that data exchange, just tearing down data sets and rebuilding them for who's made a request for it. So GP to GP is a perfect example of that, where I think from what I understand there are issues with crossing over between PMSs that again adds a lot of headaches to practices. And
okay, do we have any other questions coming through, or anybody who wants to respond to any of Jason's questions from his presentation? I think there's a hand raising option down the bottom if you'd like to chat rather than talk, or than type. Okay. Oh, Liz. Okay, let me see if I can do this. Where are you, Liz? All right, you should be able to talk now, Liz, though you are muted. If you unmute yourself, you should be able to chat.
So just at the start, my microphone wasn't working anyway, but how do you verify patients? Like you've got the correct clinic.
So how do we verify the patient?
Yeah.
Before, okay, yeah. So we'll be coming in. Our engagement with someone will be coming in sort of after that verification has been done by whomever's making the request. So for example, if it's an organization that is, just again, so it's like aged care is a perfect example. If it's an aged care provider, they've done the kind of legwork up front to verify that patient and verify their NHI number and their address and who they are, and then they kind of pass that information on to us as a way of verification. So we're putting all of that solidly on their shoulders to do it properly.
Thank you.
Sure, no worries.
Looks like Shno has got another question too, asking about the time frame for rolling this out.
Okay, cool. So time frame so it's in Medtech Alex practices at the moment, and the specific conditions filtering will be starting on next week. So the aim is to get that out by the end of June. So we have the front end part of it work. We need to do some work on behind the scenes and how that goes. So once that goes through, we'll probably be in touch, I guess, with Alex to look at doing an update to everyone to say this is ready to go. And so you might, again, the comms within the PMS might change a little bit, but we'll be again, there won't be any change or need on your part. But yeah, to be honest, I think it'll probably go for the next sort of 2 to 3 months as we also add up more practices, and these kinds of things never stop. So we'll find new features and new little tweaks, but the majority of it, the vast majority, is complete and ready to go. We're just adding more PMSs and more features.
I'll just add to that that Jason mentioned that these are for Alex enabled sites. So Alex, for anybody who hasn't heard of Alex or hasn't come up at all, one, it's not named after me. It actually stands for Application Layer Exchange. Alex is our interoperability platform at Medtech. It operates across both Medtech 32 and Evolution, and it is free to have activated for your practice. This is part of covered in your license fees for Medtech. It's part of the core functionality of the product. If you have any curiosity as to whether or not your practice has been activated, or if you'd like to get activated and aren't sure if you have been, please don't hesitate to get in touch with Activate Alex. That's ALEX at medtechglobal.com, and any follow-up emails from the Shirley team will make sure that information is included there in terms of how to activate or how to check if you're activated, that kind of thing. We do have another question from Madeline. Can all the requests be sent to one designated inbox rather than separate inboxes? We see casual and enrolled patients, and we have an allocated person currently doing these via email /GP to GP.
Good question, actually. I'll have to find out and get back to you. I would think so, but it's to be honest, it's probably more of a question for Alex and her team around if the layer, the application layer that we're using to talk to the practices will allow that. I think from our side, we could there wouldn't be an issue with us being able to, have some way for a practice to say, hey, look, this is the PMS user that handles all that. Send them to them, because at the moment what we're doing is we're doing a lookup within and finding that person's, using the NHI number, finding that person's GP, and then working our way through there to send them the message. So that's a really good question. I think that's something I'll take back to the
follow-up. For a follow-up email, we'll make sure that gets answered. All right, another one from Ian. ACC often requests information that is not related to the injury they are looking at. Will there be a way to turn off the SNOMED code that are not related to the injury?
Yes. So what you'll have is you'll actually be able to see the report going out, and you'll be able to turn off, specific parts of it if you feel that they shouldn't be there. So it can be, if it looks like they're fishing or looking for something they shouldn't be, then absolutely, you'll be able to kind of remove those one by one. That being said, I'm sort of thinking on the fly here. It's usually when I get in trouble. But yeah, a way to, again, there's a few other thoughts I have on how that could be done without that. So potentially as well, if they put in, if we have something from the system which says, it's a claim for this, we could log it back so they can't add anything else. That could be a pretty surefire way, I would think. So kind of policing it to say like, okay, so if the claim is for this injury, that's all you're getting. That's a good question. That's interesting. I'll have to think about that especially because we're talking to ACC in the next 2 weeks. So bringing that into the conversation will be good. Since we've been to edit clinical notes, you'll be able to redact them. So you'll be able to go through and say, basically tick a box to say, nope. No, I don't think these should go, but everything else can. So you'll only be, so on the notes perspective, you'll, anything that, only what you're comfortable really with sending through is what's going to go through. So it's sort of an all or nothing kind of approach.
Beans. Did we have any other questions for Jason? Of course, I don't know if any of you are like me, where I might not have any questions right off the bat, but when I'm struggling to get to sleep at 3 a.m., if they pop up, of course, always happy to answer questions, or I'm sure Jason and his team will be happy to answer questions if you think of them after the webinar. We've got a suggestion from Shanoa down the bottom. As a future enhancement, could you include requests from patients where they have authenticated their identity to release their medical notes directly to them?
Yes, I think that's a great idea. I know Hira is working on, I think they have some of the patient identification through my health record. That's kind of up and going. I absolutely. I think, and that's part of the thing we've been waiting for, is kind of seeing how Hira goes through, and when it's a bit more of an open ecosystem, when companies like us can work with it, we'll want to be kind of first in the queue for that exact purpose, is that someone can authenticate through Hira, and Hira can say, yep, this is who they said they are. You can send them their notes to their email address or to their contact details, and off it goes. So we're just waiting on them. And can you go over who is verified? So at the moment, it's still very early days, so we don't have any organizations. We have a lot of meetings and a lot of pitches and this kind of thing. But what we're targeting in the early days of this for the verified organizations will be telehealth and aged care. So I think those two aspects of healthcare have that need for acute access to health information. oftentimes is very, I mean, you think of respite care and aged care, and there's no planning. It's like someone just shows up one day, they're there for a week, and so they're having to, the aged care providers having to kind of scramble a bit to kind of work out, any health conditions or anything they need to be aware of when that person comes in the door. And same thing for a telehealth, where it's oftentimes used as a sort of late night solution to seeing a GP when after hours clinic will be away for several hours. So at the moment we're still working through the processes, but I think we'll have a couple of them signed on over the next few weeks. And ACC as well, we're already doing a lot of work between ACC and their EC Enhanced Care program. So we're just starting those conversations with them to work on the focus will be critical claims, so where they need a claim done pronto. And can it be used by overseas companies, like say from Australia? We haven't seen it yet. I don't think we would at the moment. I don't think we could control it very well if we had someone from overseas asking. So yeah, I think so at the moment I would say no. It's purely a New Zealand only kind of thing. If we did anything overseas, we would probably set it up for the Australian market. So if you're in Australia, you would be connecting to PMSs and health records in Australia versus being able to cross the border over here.
Okay. Anything else that anybody wants to ask while we've got Jason with us? All right. And like I said before, there will be a follow-up here. So if you do think of a question later on, I'm always like that. I always think of questions only after I've got access to the person. So never hesitate to get in touch with us and ask us to either get an answer from the Shirley team, and of course we can certainly provide those contact details for the Shirley team as well. And it looks like Jason's just popped his email down the bottom. So so please do ask questions if they do crop up after the webinar, after you've done some mulling or you've discussed with your colleagues or anything like that. So we will be passing all of these questions on to the Shirley team following this webinar. So all of those questions and answers, I know we had at least one where it was a kind of, we need to probably check on that. That was a really good question, and we'll come back to you as soon as we've got an answer. So thank you so much to Jason for taking the time to share with us today. We really, really do appreciate it. And I also want to recognize and thank all of our attendees for joining us today. Time is precious to us all, but oh my gosh, in primary care, it is non-existent. So we really do appreciate you taking the time to come to ask questions, provide feedback, all of that good stuff, because this is how we get better products working with Medtech. So thank you so much. Thank you all. Hope you're staying warm in this wintry blast and have a great long weekend.
Thanks, everyone.